Our next speaker reminds us that it takes strength and determination to be a doctor. But Dr. Sherry Blauwet gives new meaning to those words. She is the only doctor in Boston who has won the Boston Marathon and the first Paralympian to be named to the International Olympic Committee. Her research topic is Soar with Strength, probing the power of Paralympians and adaptive sports athletes. Please welcome Dr. Sherry Blauwet.
Thank you, Lisa, for the very kind introduction, and thank you all for being here with us this afternoon. So, Boston is a sports town, and we all understand the power that sport has in our lives, both as individuals as well as a society. Whether you like to play casual pickup games with friends or put it all on the line for a big win, we've all experienced that unifying power of sport and its remarkable capability of bringing us together to meet a common goal. Perhaps more importantly, sport provides an outlet for people to get regular exercise in a way that's engaging and sustaining. The CDC recommends that all adults obtain 150 minutes per week of moderate intensity cardiovascular exercise to maintain basic fitness. Even better, add in some muscle strengthening at least twice per week, and you'll be on your way to success. So, sounds easy, right? How many of us achieve that most weeks? Now imagine if your world were literally turned upside down by a serious injury. For example, a car accident resulting in a spinal cord injury. Do these exercise guidelines still apply to you? From our perspective, the answer is yes, but sort of. People with SCI still need to exercise, although the dosing recommendations may be somewhat different. Additionally, for most people, once formal rehab comes to an end, they feel as though they fall into this gap of reduced access to physical activity, leading to a downward spiral of sedentary behavior, deconditioning, and sometimes risk for chronic disease. Well, here at Spalding, we're focused on creating strategies to help bridge that gap to healthy living and community-based exercise and sports for people with disabilities. In this context, adaptive sports have a huge role to play. So adaptive sports are opportunities that use adaptive equipment, enhanced rules, or both to give all individuals the ability to play, regardless of physical or cognitive prowess. For some, it may be joining an adaptive sled hockey team, like the picture here on the left, to build camaraderie, battle social isolation, and engage in regular exercise. And for some, it may be getting back on the road to get that runner's high in training for the Boston Marathon. For all, we feel that participating in adaptive sports leads to an incredibly powerful confluence of impact when we're able to simultaneously improve physical fitness, improve mental health, and reduce social isolation, all of which are far more prevalent in individuals with disabilities. For example, up to 25% of people experience depression after spinal cord injury, and up to 40% report feeling isolated from others. But as with all things, truly excellent programs are data-driven. At the Kelly Adaptive Sports Research Institute, we see this as an issue of addressing participation across a continuum. At the entry point, how do you get people with disabilities involved in sports and exercise, and how do you keep them involved? And once they're hooked, once they're part of the program, how do you promote healthy participation for many years to come? Addressing the question of how to get people involved, as a first step, we took a look at our database over several years of people who had come to the programming, and we isolated details regarding demographics, functional impairment, and their participation logs or their history to see who continued coming over several months to years. And we think that sustained participation is really important. It's an indicator that the individual has adopted this as part of their lifestyle of being active and out there and engaged with others. We discovered that a hub and spoke model was more effective at sustaining participation rather than a centralized model. Here you see a heat map indicating that sustainers, indicated by the red dots, were far more likely to attend the program site nearest to their home. Fairly intuitive, but important when we think about how we run our programming. But we still feel like we needed to take a deeper dive. We organized a series of formal focus groups to solicit direct feedback from our athletes. In doing so, we heard from them that domains of physical access, beliefs and attitudes, interpersonal relationships, a sense of physical well-being, and the environment all had a significant impact on participation. And this complex context of multiple barriers affecting someone's ability to come to the program and be a part of it is very unique to adaptive sports in comparison to able-bodied sport. Our next steps will involve prospective, systematic data collection with use of a large database that's been developed for the Spalding Adaptive Sports Center's program under the leadership of Mary Pat Stone and her team. And this will be a large undertaking. We know we have our work cut out for us, but if successful, this will be the first research of its kind in which we're prospectively monitoring the impact of adaptive sports programs on individuals' health. Importantly, along the way, we developed innovative clinical programs. For example, competitive athletes can come for an evaluation in our adaptive sports medicine clinic for an interdisciplinary assessment that's really looking at health and performance, getting out there and competing at one's best. And for those just looking to stay fit, they can be seen by our certified inclusive fitness trainer, Allison Kane, to develop a personalized fitness program. Turning to the other end of the continuum, addressing the needs of competitive athletes, we've collaborated with the International Paralympic Committee to perform epidemiologic studies of Paralympians to better understand patterns of musculoskeletal injury. And this work has demonstrated that elite athletes with disabilities show a higher risk of injury and also different patterns of injury compared to elite athletes without disabilities. For example, we know that the shoulder is at particularly high risk in athletes who are wheelchair users for both sports as well as daily life. The shoulder is a very shallow joint with the glenoid or the socket only covering approximately 20% of the humeral head. Many people compare this to a golf ball on a tee. And in wheelchair users, interestingly, the shoulder becomes a weight-bearing joint during transfers, as depicted in the bottom picture here, leading to repetitive, excessive force on these soft tissue structures that are helping to support that shallow joint. Importantly, sports-related injury can lead to significant dysfunction and impairment later in life for our athletes. For example, those who experience a rotator cuff tear and ultimately require a shoulder scope or repair of that tear have to make significant changes to their lifestyle for up to 6 months in that postoperative period, often taking time off work, hiring a personal care assistant, shifting from a manual chair to a power chair. This is a really big deal in someone's life, all because of a sport-related injury earlier. Ultimately, the shoulder can develop what we would call progressive tissue failure, full thickness, rotator cuff tears, and even early osteoarthritis, leading to the need for joint replacement at a relatively young age. In sports medicine, we often talk about the phenomenon of ACL tears leading to early knee osteoarthritis, and we call this the young athlete with an old knee. And I think that a similar phenomenon and concern exists in adaptive sports athletes in which we see the young athlete with an old shoulder. We're seeking to gather a further understanding of the pathophysiology of shoulder soft tissue injuries with a novel study using musculoskeletal ultrasound and correlating these findings with physical exam and shoulder pain symptom scores to better understand how pain correlates with true pathology. And this is being done in the sport of Paralympic track and field. Another important facet we've recently tackled are the needs of female adaptive sports athletes, which are a very unique population. Relative energy deficiency in sport, or RED-S, is a syndrome through which athletes do not intake enough calories to fuel their needs, particularly related to performance, but also building adequate bone mineral density. But although this is well known in the literature, we don't yet know how it impacts adaptive sports athletes. We surveyed up to 600 United States Paralympians prior to the Rio and Pyeongchang Paralympic Games and found many concerning factors related to RED-S. For example, the majority of athletes demonstrated eating behaviors that were concerning, such as attempting to lose weight or attempting to change their weight to improve performance. And we found a very surprisingly high prevalence of stress fractures. To finish, I'd like you to meet my friend Maddie. She's 8. She's got a hot pink racing wheelchair, and I'm certain that we'll see her on the track at the Los Angeles 2028 Paralympic Games. What's clear is that ultimately we're looking to create a true paradigm shift in which disability is not equated with being sedentary or with social isolation. And we're using the power of sport as a catalyst to achieve this for ourselves as well as for athletes like Maddie. Using evidence, we are probing and will continue to probe the power of adaptive sports. Thank you.